But it's an honor to have him join us again for IBD Horizons surgical discussion.
Good afternoon. Thank you so much for sticking around for the surgeon to speak. And let me ask, how many surgeons in the group? All right. Thank you for being here. So it's a privilege being here. In the next 25 minutes, I'd like to tell you about some of the things from the surgeon's perspective. And, first of all, I have nothing to disclose. This is a humbling disease from the patient's standpoint of view, from the family standpoint of view. It's a lifelong disease. So it truly needs a commitment from a collaborative approach from the gastroenterologist's part as being the lead doctor in this patient's cares, complemented with the surgeons on and off. So this brings a unique problem because I don't think globally, nationally, and internationally we have done a good down so far, and we're getting there slowly but surely with a collaborative approach. Patients see the physicians being divided, and they feel like sometimes they can get stuck in the between, and it's very important for these things to solve this. The timely discussion of the surgical options in the presence of gastroenterologists and the surgeons is very critical. And it's also very critical, rather than pumping the drugs forever, to define when and how it will be time to consider the surgery, rather than in an emergent situation, having the surgeon being a Dr. Evil with a knife at the hand waiting, now here's the bad guy to take it over from here. I mean, I've seen the both sides of the things. When you ask in these meetings the gastroenterologists, for the surgeons, they blame the gastroenterologists that the patients are not coming to us. They don't know what they're doing. They come to us really late, all these complications. When you ask the gastroenterologist standpoint of view, the fair thing that exists from their part is, well, this is a very tough, complex problem. Our patients go to a general surgeon. Our country, U.S., is so huge, and these patients get diluted in the surgeon's hand, and we get surgical complications. Now we have to deal with it. Now this is blamed to us as a new type of disease that we are treating a surgical problem. So both sides are right. So in order to break those barriers, I think it's very important focusing on patient collaboratively as a team-spirited approach. Clearly define the referral for the surgery. What do I mean by that? I tell the patients, it's a commenting on the IBD patients, they decondition themselves. Social restrictions, work restrictions, diet restrictions, sexual restrictions, and then they suck it up for the sake of the family, don't complain and move on. I think that's very important to relate to them. You, with an IBD, should not have any lesser than a normal population to have a normal quality of life. I feel passionate about that, and maybe it's a little bit extreme, but they need to understand the fact that there are solutions for their problem. Sometimes it needs surgery, and better understand the contributing factors. This is my key line in my teaching that I always say. It's okay for the IBD to get complicated, but do not get the complication to get more complicated. I think that's very critical. Let's talk about the UC. So these are the surgical options we have. The first option is the total abdominal colectomy and an ileorectal anastomosis. It's rarely done, but it can be done in certain circumstances. In this situation, we remove the colon and hook the things up to the rectum. What circumstances we use in patients that are not candidate for a J-pouch procedure, specifically when there's a diagnostic uncertainty whether somebody has a Crohn's or ulcerative colitis with a spare rectum. So these are the patients can be a good candidate. The other patients that can be a good candidate, relatively normal appearing rectum, and a young lady who is really concerned about the fertility issue can be also a good candidate in these settings. Total proctocolectomy and ileostomy. I think this is still a very good option, which is removing the whole colon and the rectum and giving somebody as an ileostomy. These are the patients, once again, not good candidates for a J-pouch procedure or a failed pouch procedure, or patients with a rectal cancer. Can still be an option. I tell this point to my patients. If somebody can live with an ileostomy a good life, trying to convince them one way or another for other options is really unfair to them. So this can be still a very good option for many patients. The other one, this is really a little bit boutique surgery, but this used to be pretty popular before the J-pouch procedure come across. It's the content ileostomy, or the other way we call the cock pouch. in our country, other groups do also called a Barnett pouch. I happen to know how to do the cock pouch. That's the reason I prefer doing a cock pouch in these settings. When the patients are not a candidate for a J-pouch procedure, and they're very reluctant to accept to live a permanent ileostomy, in these patients where they intubate their ileostomy 3 or 4 times a day, where there's a nipple valve there, it's a one-sided valve to empty their stoma. This can be a good option in these situations, but it's not something simple. This is the study that I have done with one of our research fellows many years ago, that it needs a motivated surgeon, but it also needs a, more importantly, motivated patient, because the risk rate of these patients is around, revision rates around 3 over 10 years' time. So they need to understand the fact that that nipple valve can be an issue. But when somebody loves this content ileostomy, it's really tough for them to go back to a permanent outside ileostomy. It's an option that can exist, and we usually do it today when we convert the J-pouch procedure if it fails, and they're still reluctant to accept to live with a permanent ileostomy, can be a very good option. Now, sometimes we do a subtotal colectomy and ileostomy, which means removing the colon, leave the rectum behind. Most of the time today, we do this procedure as a first stage of the J-pouch procedure. So as a gastroenterologist, you're going to hear from the surgical aspect, 1 stage, 2 stage, 3 stage. 1 stage means doing everything all at once in the sense of removing the colon and rectum, doing a J-pouch, and creating an ileostomy. 2 stage is when you do remove the colon and rectum all at once, hook the things up to the anus, but give the patient an ileostomy for 3 months, and close the ileostomy at 2nd stage. That's called 2 stage. 3 stage is this one. The first stage of the 3 stage, when the patients are sick, comorbidities, high-dose steroids, a significant amount of immunobiologics, albuminuria, anemia. These are the patients I'm very liberal about staging them with the initial colectomy. Then come back to do a J-pouch procedure around 4 to 6 months' time. Now, this is, in my opinion, today, is the gold standard surgical approach in patients with ulcerative colitis and familial edematous polyposis and selective cases with Crohn's disease. So what we do in this setting, we remove the rectum and the colon, but we put our finger and we use a staple gun to come across the rectum. There are 2 types of anastomosis we're going to talk about, and my preference is doing a staple technique. We will talk about the reasons behind. Then what we do in this setting, that we remove the rectum, and then we create a J-pouch with these linear staplers that cuts and staples, create this pouch, staple the tip of the J-pouch and oversew it. Subsequent to that, we bring this staple gun, which is a circular cutter and stapler, to hook the pouch to the anus itself. So it is sometimes much easier said than done, so there's a significant amount of technical things that can go wrong in these settings, such as this one of these disastrous complications incorporating into the vagina. So why I'm trying to say this thing, this procedure is not a procedure that should be taken lightly. It's a procedure, in my opinion, should be done in experienced hands that who does this weekly rather than once in a blue moon. Otherwise, the complications and the outcomes on these patients really becomes a big burden to them, to their family, to you, and to us as a society. And then we do the staple anastomosis. This is a circular stapler and cutter, and we check for a leak. If there's no leak, we give an ileostomy for 3 months. This is a surgical simulation of that thing. So assess the area, that cuff that we plan to leave, which is around 1 to 1.5 centimeter of anal transitional zone behind, to insert the stapler to create the stapled ileal pouch anal anastomosis. We bring the staple posterior to the suture line, so inadvertently we don't grab the vagina when we close the stapler. But again, there are a lot of things that goes wrong. This pouch can rotate, and patient may have a valvulized anastomosis, and most of the time this gets ignored by the surgeons because we are the surgeons who makes the ego bigger than the Mount Everest. We can never do wrong. So you will be chasing us and picking up our complications and putting us on the spot, and tough to pick up sometimes. So this is the ILA 100, or a stapler gun, to come across the small bowel to create the J-pouch. Again, innovation helped us a lot in the surgical management of these patients, but critically, I think it really helped these patients to avoid a permanent bag by bringing ease how we create these things. So this is the way how we create a J-pouch procedure. Now, again, as what I said, this is a procedure that the things can go around. I tell everybody, to my residents and fellows, that this is something needs to be done the specialist's hands. Anybody can do a straightforward J-pouch. The question is, what do you do when you feel sometimes that things don't reach? Trust me, you look at the door, the door looks at you, and there is nobody's coming there, and to give you a hand, and you're stuck there with the patient that who may end up with a permanent bag. So you must know the things. So this is not the type of the anastomosis that we like to leave it behind, because this is going to stricture, this is going to fistulize. Guess what? Then it's going to be labeled as a Crohn's, and you will be getting this patient, pump the biologic, pump the steroids. Now my diagnosis converted from ulcerative colitis to Crohn's disease. So this is the type of the anastomosis that we like, a viable, with tension-free, hooking the things up to the anus. We got to put humor to what we do on a daily basis, trust me. So this is how you come across the staple line again. Make sure that I always try to teach to my fellows the art of colorectal surgery to be able to think the things a couple steps ahead. So the previous slide was showing us don't go too low. And then there are certain techniques that we come across the mesentery where we excise the ileocolic artery, score the mesentery. Why I'm showing this thing, a little injury to this area may be equal to a permanent bag when you get into the SMA. So I think it's very important, once again, to have these things done in a high-volume centers. And the J-pouch, most of the time it reaches, but if the things don't reach, you may have to do a S-pouch, which was the initial type of a pouch that was designed. Because of the difficulty of creating and a good old grandma suturing technique, we pretty much stopped doing it. The critical on the S-pouch is the exit conduit needs to be 2 centimeters or less, because if it doesn't, then you're going to create a problem on these patients that may be really, really presenting you with the obstructive defecation. So if you have an S-pouch and you get into a tunnel and suddenly 5-6 centimeters later you come into a huge cavity, trust me, there's some exit conduit problems. The other important thing on these patients, couple years to 3 to 5 years, these patients do okay. They suddenly present 3 to 5 years later with this obstructive defecation, so knowing the surgical history is very important on these patients. Now, this is the simulation. Okay, it didn't work out. Oh, there it is. The excising the things and having the things to come across to be able to have the things to lengthen so the things can reach down to the level of the anus on these patients. So it can be a humbling and tough procedure. And anytime, if you have any doubt, put the finger to patient's anus, make sure the things do reaches. It's not uncommon. I get a phone call once or every other 1 to 2 months. The things are reaching, and I say, and say, but I excise the pouch, I'm making a new one. That's the part that I said, don't. In these things, if the tongues don't reach, just leave the pouch in there, retreat. This is one of the toughest things to teach. Believe me, it was tough for me to learn too. Retreat is a sign of maturity. Just back off. Come back another day. The mesentery elongates by time. You can send the patient, but you excise that pouch, you're going to cripple that patient with the next time the other guy is coming. The pelvis is going to scar down when there's nothing in there. So this is very important to check the things, make sure it reaches to the anus. So let's talk about some of the controversial topics. One thing is it okay to do the elderly? I tell everybody it's common sense. If somebody is really well fit and doing well, I'm very liberal about doing a J-pouch procedure. The eldest person I have done was 80 years old, but he was incredibly a well-fit guy, and he said, I don't want to live with a bag. He's doing really well. Sometimes we do a study to prove the things that we should not be proving. You should not be doing a J-pouch in the setting of toxic colitis. These patients need to be staged, otherwise you have really bad results. In the setting of a colorectal cancer, it's okay to do it as long as you don't compromise in the intent of cancer surgery. So it's okay, but make sure you do not give a radiation post-pouch. They lose their pouch, they end up with a permanent ileostomy. So if somebody needs a radiation therapy, they need to be getting beforehand. So this is a big controversy, the way how we put the things back up. Patients who get a mucosectomy versus a stapled anastomosis. As what I said, I'm a liberal proponent of a stapled anastomosis. This was a big deal issue. The physicians who advocated mucosectomy because they believe the fact that we are leaving a symptomatic cuff behind and a risk of dysplasia cancer versus, we and my group of the surgeons thinking better function, less complications. I think this was evolved through times. In the past, with the staples we decided to use staples, and the proponents of the mucosectomy, they said the fact that you're doing shortcuts, you may be leaving longer rectum than behind. Now, in this day and age, be careful the MIS, and there's nothing doing the things MIS. I'm a big proponent of the MIS. I think in order to avoid incisions, surgeons unintentionally leaving a long rectal cuff behind. So if you're doing a scope and that patient's anal canal or anal transitional zone is more than 2 centimeters, there's a problem technically from the surgical aspect that we may have converted an ulcerative colitis problem to an ulcerative proctitis problem, and suddenly it became your problem that you're dealing with that's not going to be fixed. So it's very important to know what's the length of the cuff that was left behind. At least in our hands, the results of the stapler all along has been better than the mucosectomy. What's the true risk of the symptomatic inflammation in these settings is pretty low. And what's the risk of the dysplasia in the setting? It's pretty low. This is the first study, one of my first papers I ever done. You get cocky, arrogant, bam. The next thing that you do is the fact that, you do get a cancer in these settings on these patients. So you always need to be humble. So we look at these results overall, it's a real deal. These patients with a leftover cuff, with or without the mucosectomy, that area may need a surveillance to these areas. So one thing is that overall there were 11 cancer patients that we found out, and the common thing that we found on these patients was not about whether it was stapled, chronic inflammation, Crohn's disease, chronic pouchitis, and severe cuffitis. These are the patients I think we need to be surveillancing pretty aggressively. So the other thing is, as can be seen, the mucosectomy didn't give them a proof of not getting a cancer. Why? Surgeons are not some computerized machine excising the mucosa, not leaving any cancer or cells behind. Contrary to that, you're excising that mucosa and then bringing the pouch down and covering the area that you cannot surveillance. So that's the reason I'm a big liberal of stapled anastomosis, unless patients do have a rectal cancer or a lower two-third is dysplasia. These are the patients I prefer to do a mucosectomy. And these patients are pretty much safe to do a stapled anastomosis if they have no risk factors after the initial evaluation under their gastroenterologist every 2 to 3 years. But if they do have a colon cancer or associated high-risk factors, these are the patients that I would like to have them to be scoped on a yearly basis. J pouch or S pouch itself, that there's no big difference, that the J pouch gives the best results, much easier to do. That's the reason we prefer J pouch. Now, avoiding an ileostomy. This has been used as marketing for so many times. So if you come to us, we don't give you an ileostomy. I'm completely against this thing. These patients should be selectively picked up for no ileostomy in these settings. Experienced surgeon, elective procedure, motivated patients because the postoperative period is tough, low-dose steroids, no immunomodulating agents, and uneventful operation. In these settings, it's quite all right to have the procedure done as a one stage. It's okay to do it in indeterminate colitis. And the Crohn's data, we start to get more liberal about that. Why? Because when we look at the things that we selectively did preoperative diagnosis of Crohn's disease, those patients did well. Sometimes, selectively, that the patients get a diagnosis in the colectomy specimen in the 2-stage procedure, they did well. The patients who did not do well, everything picture perfect ulcerative colitis, they later on declared themselves as a Crohn's disease. Those patients didn't do well. So in the era of the biologics and the teamwork and everything, we started to become more liberal, and we can talk about indications for that. Consider on a patient who cannot live with a permanent ileostomy in the setting of Crohn's disease, the possibility of a J pouch procedure. Type of delivery, the literature says vaginal delivery is safe. I don't believe that, at least in my hands, that these patients do worse, that the vaginal delivery has higher risk of impact to the vagina, quality of life. So I'm pretty liberal about recommending my patients an elective elective C-section before the term starts, because if you get the hormones involved, the delivery starts, it's going to have the same impact to the sphincters itself. So I do recommend the C-section on these patients. Laparoscopy MIS is an excellent option in these patients as long as there's no shortcuts what needs to be done. And even it can be done in a single port and everything. Again, this should not be used for marketing. This should be used selectively in patients without any compromise what needs to be done in this setting. This is one of our, the patient who underwent a J pouch just through the ileostomy side. And this is the result that I published this last year before I left the Cleveland, that over 4,000 patients, and when the things go well, these patients do well. Let's talk about the Crohn's disease. The disease as known as the Crohn's disease, but we have to give the credit about the Oppenmeyer and Gisberg. I think they never talked to each other. Is that right? That Dr. Crohn's, because of the alphabetical order, got the first authorship, and they have never been friends, what I understood. Tom, you can agree or disagree after that. But this is a Crohn's disease. Let's be clear. As much as all these wonderful drugs exist, and I cannot wait the day that I don't need to function as a surgeon, there is a 70 to 90% of the chance these patients will require surgery at one point in their lives. The things that the indications are this, and there's a many of them, and the number one reason that we still operate on these patients is failure of the medical therapy. That's the unfortunate reality that we have to accept. And once again, I cannot wait the date that I don't need it in caring of these patients, but unfortunately that is not the case because it's a tough disease. So when you deal with Crohn's disease, that you need to understand this is incurable. Surgery is most exposed to intestinal complications, and operations influenced by many factors, and asymptomatic disease should be ignored. So these are some of the level 1 evidence for indication for surgery. So when somebody has a stricture, penetrating disease, hemorrhage, growth retardation, neoplasia, these patients do well with the surgery. Operative options. The first surgery that was done was a bypass. Which president had a Crohn's disease? Let's see. Anybody? That's it. Dwight Eisenhower actually got a bypass procedure, internal bypass. But because of the mucosal and the cancer risk in the excluded segment, that we have stopped doing the bypass procedures. So the only bypass procedure we do right now is just a diversion. The two common procedures that we do is a resection with or without anastomosis, or a stricturoplasty itself. So these are the indications of the internal bypass that we stop pretty much doing it. The only other procedure we do sometimes is the gastrojejunostomy for a severe duodenal Crohn's disease. Resection is the procedure of choice, and this is the way how we assess the line of the resections. Still grossly, not with frozen, because we have done this study. If you do a frozen resection, I think you will be resected unnecessarily more than bowel that you need to, and you're giving the patient a tough life maybe in the long run. The way how I assess is my fingers. I put my thumb to the index finger where the mesentery comes. I can just touch the other side easily. That's a nice area with no mesentery. You can put the things back together. Now, when talking about the resection, and I'm not saying that this should be like we should be stopped not treating these patients and surgery first. Selective ileocolic Crohn's disease can do as well as the biologics therapy. So these are the patients who will fail the conventional treatment, non-obstructing disease. The Dutch group in Europe, they have done that. They have showed the fact that these patients required surgery around 19% in 4 years, and the patients who did not go to surgery arm required surgery around 40%. Now, you can make an argument, well, 60% of the patients that avoided surgery for 4 years. But every quality of life in these settings, when they're followed up, it was not statistically significant, but the numbers were small. The surgery patients did overall better. So it is an option exists there for a limited disease. Inflammatory disease, this can be a good option that can be considered. It will be a tough pill to swallow on this side of the Atlantic, but can be considered. I had 2 patients come to me like that in the last 1 year. Stricturoplasty itself, it can be a good option in multiple strictures and long segment, existing or impending short bowel syndrome. And these are the contraindications, hint for the question. There is a stricture, phlegmon, you should not be doing it, or colonic strictures, you should not be doing a stricturoplasty. There are different types of strictureplasty. We lay it open and close it longitudinally. This is called the Heineke-Michelitz itself, and the medium-length strictures itself that we close it either a Finney, side-to-side anastomosis, or the other way we do that, the Jubilee, not laying it all open, leaving the disease area intact, and doing a side-to-side anastomosis. I think this has become a very, very good option than a resection. The other option is like the longitudinal or side-to-side anastomosis in patients with an impending short bowel can be a very good option to be considered rather than giving them a shortcut for the rest of their life. So when you get strictures in the surgery, it's an art. You got to assess the whole gut. So you use the whole for your advantage, put the things, and I have this little bowl that I got it from overseas. I run the bowel. People use a Foley or something, but I want to make sure that I don't miss any strictures in those areas. Anytime that the bowl doesn't pass, when I'm there, I make a strictureplasty. Liberal about the stoma on these patients because these patients have a severe jejunal ileitis. I like to divert them 3 months if they have so much of a suture line, and especially their number one friend is the biologics to avoid the disease not to come back. I rather give them ileostomy for 3 months, having them to be upset to me, but dealing with aseptic complications and take the drugs away from them in the long run. Biologics, I don't blame the biologics as the number one reason of the complications for my deficiencies, but I do believe that delayed presentation referral to surgery is the number one reason, complemented to biologics. And, scientifically, it impacts healing. So we should not be offended with that, but we should not be also blaming the biologics for our own failures. So this is one of the old studies that we have done. Again, laparoscopy has good advantages, and strictureplasty has good results with accepted morbidity. This is when the disease comes back, it comes back at the area different than the disease. So colonic disease, I think segmental disease is an excellent option compared to the total colectomy. And when you look at the results, the recurrence rates are pretty much the same. When they remove the whole colon, a lot of patients ask me, will the disease come back? The disease comes back rarely, 3 to 15% in most of the studies. Most of the times these patients do have a problem at the area of the ileostomy side itself. 2 minutes, 2 minutes for the endoperitoneal disease itself, for the fistula disease, how does it look? Again, these are the ones I beg to our gastroenterologists that less is more surgically. I cannot fix this. You gotta help me, you gotta help me. Biologics, avoid the surgery. And these are different surgical options that exist. Ceton is an excellent option. The aim of the perineal disease, unless it's a rectovaginal fistula, symptomatic one, is not to cure these fistulas, to drain them well so they avoid a permanent ileostomy. That's the aim of this thing. So I leave these cetons 6 months to a year, remove them, and they do well most of the time. Fistulotomy, I don't like to do that because it creates an unhealed perineal wound. Flap procedures is like flipping a coin, 50%. Let's not make it up as a surgeons that we have a good success with these ones. These are really flipping a coin type of options. We need more than the surgery for perineal disease to take care of these problems. Different type of flaps, rectal sleeve, and this is like pushing the limit. I have done these like selectively, around 60% with 2-year success rates in patients who cannot live with an ileostomy. It can be an option with a very bad perianal fistula. With a normal colonic disease, you pull the colon out, have the things to stick there to this area, and amputate that stump 5 to 7 there. Again, it looks like gross, but it may be eccentric, but it's rare. I don't want to sound like as a first line of therapy. Fibrocilin doesn't work. My future, I do believe, not my future, but the future of the surgical perineal disease is stem cell, stem cell, stem cell. Company needs to find a way to cut that cost. There's no way that's going to fly with that amount of money. Diversion, patients need to know when they get this thing that they get as a bridge to a treatment. If somebody gets a temporary ileostomy, most of the time it's unlikely that ileostomy will be closed, but I'm getting more optimistic with the presence of the new biologics that it may restage the clot. We start to get close these ileostomies more, but the patients still need to know this is more of a bridge to a permanent treatment. So this is my pretty much conclusion. I think the IBD is a pretty much tough disease for us. Specifically from the surgeon's part is the most frustrating aspect for the surgeon. We need you. When a gastroenterologist prepares the patient, sending the surgeon, look, you may need a bag for 3 months or so. Don't make a big deal out of it. You have no idea what type of a positive impact you will be doing on these patients rather than the surgeon is blamed as, oh, he's not good enough that he may be getting ileostomy for these patients. So as what I said, solution is very critical on these patients to work together collectively. Looking forward to seeing you guys next year in our meeting, and thank you so much for having me here as always.